The patient has a choice of gemcitabine Abraxane versus FOLFIRINOX. Those are the two standard treatments available in the metastatic setting. How do you go about deciding which treatment is most appropriate for the patient? This really could be a dissertation, but I'll just try to summarize what's important. So our patient has a good performance status. They are in their early 60s. They have a performance status of 1. We've corrected their biliary function, meaning we put in a stent. They're less jaundiced. Their liver function has improved. So you have to present to the patient, well, we have these two treatment options. Gemcitabine Abraxane is given weekly. It does have side effects, the typical myelosuppression. It does cause peripheral neuropathy. It's given weekly. You do not necessarily have to put in a port. You don't have to wear a pump for 48 hours as you do with FOLFIRINOX. Gemcitabine Abraxane was tested in the United States in the majority of patients. It was tested in the community. So the point is that it may be a more amenable combination to use for those patients that are not treated only at academic centers. In contrast, FOLFIRINOX does require full doses of all the drugs included. Again, oxaliplatin, irinotecan, bolus 5-FU, leucovorin. So it is a more intense treatment. Patients do have to wear the pump. They do have to have a portacath placed. And just the schedule, it's every 2 weeks. But typically, patients do have to have an extra couple days after the treatment is given to recover. So you think about it being every 2 weeks, but they can be out of work, for example, for up to a week. Giving a weekly combination of Abraxane and gemcitabine, patients may feel nausea for 1 or 2 days, but are hopefully back to work for the remainder of the week. And certainly they can be monitored more closely because the treatments are being given weekly as opposed to, administering all the chemotherapy and waiting for the next 2 weeks to see how they do. Important other considerations are whether folks need growth factor. Okay, so do you need Neupogen with a weekly regimen, or do you need Neulasta with FOLFIRINOX? And that's also important when we talk about the cost of the treatments. The supportive care is different with FOLFIRINOX versus Gem/Abraxane, and the supportive care cost can be threefold as high. Additionally, cost is also important when you talk about Abraxane Gem versus FOLFIRINOX, and believe it or not, Abraxane Gem is about $3,000 less a month than FOLFIRINOX, which many people would believe is less costly because all the drugs are generic, but importantly, there is a higher need for supportive care. In terms of outcome, there is an 11-month survival reported with the FOLFIRINOX regimen as opposed to an 8.7-month benefit in the gemcitabine Abraxane. And so patients will commonly ask, which regimen will I get more time with? But you have to balance that, again, with the side effects. And if you go back to some of the trial results, you will also see that patients that were given gemcitabine Abraxane that had good performance status had very similar outcomes compared to the 11.1 months seen with FOLFIRINOX. So they could achieve outcomes as long as 12.6 months. And so one can argue that in good selected patients, patients with well-controlled symptoms, they can indeed reach outcomes that are seen with FOLFIRINOX. We discussed the treatment options with the patient, and we talked about the outcomes of the two trials that evaluated the two regimens. We talked about the toxicities. We talked about some of the costs and some of the logistics of therapy. Our patient needed to continue to be active. He could not be in the bed or sidelined for long periods of time. He did have a good performance status, a ECOG of 1. And so all of those factors helped us, the patient and the providers. It's never just the providers that make that decision. You need the patient's input. But at the end of the day, it was the patient decision to go on to gemcitabine Abraxane. The patient received 2 months of treatment, 2 cycles, and CAT scans were performed, which revealed tumor response. The patient went on for an additional 6 months of therapy and again had stable disease. So they clearly benefited. Their quality of life was maintained. They were able to manage the toxicities, which again are neutropenia and thrombocytopenia and neuropathy. All of these symptoms were managed, and the patient benefited as he responded and also had stable disease.